Uh, Good evening, everyone. It's a great pleasure to be with you, and thank you very much, Egyptian Venous Forum, for inviting me. My role in this debate is pro use of dedicated Venous, and, uh, and I'm really looking forward what my older brother, Dr. Omar, gonna say contra this because the use of dedicated stents, which like 25 years back was the first large size wall stents, was a real game changer in the management of the venous disorder. Anyhow, it's very difficult to manufacture a venous stent. Like there is no ideal venous stent yet, obviously, because you have to combine these capabilities. Very strong radial force, because these are fibrotic lesions, very elastic. Uh, because of the dynamic character of the venous bed, it needs to be resistant to the crash. It needs to be very flexible because of the groin, and it needs to be durable in a multi-axis section, as we'll discuss it. So manufacturers were trying to come up with like ideal stent, which hasn't happened yet, because you have to, there are like different type of stents with a different type of resistance and the flexibility. The problem is also the location of stenting, because in different side of the venous bed, you need a different capabilities of the stent. You need a very high radial force at the level of May-Turner compression point. Then you need a radial force combined with the flexibility, because the iliac veins are very tortuous in the mid region. And then very often you have to pull your stent all the way down to the inguinal ligament, and this segment needs to be kink resistant, very flexible, and it cannot fracture. And that's very difficult to make. As you can see, the flexibility of stents are quite limited. This is the chart which is showing how difficult it is to combine strength and the flexibility. These are different type of stents, and we've been using them all in a way, and you can even combine like different characteristics of different stents in a different locations, obviously. The problem of the large diameter of the stent is coming with the problem of foreshortening. Obviously, you can see that some of these stents are actually getting shorter of almost like 1/4, and it's the same with the wall stent. So, because especially in the proximal part, you have to really place the stent very precisely. It might be a problem. These are the IDE trials where, the outcome of different venous stents were very favorable. And honestly speaking, they all work. Yeah, much more important is to precisely position stent and size it. Sizing is more important than what kind of stent you're gonna use. So these are like the most common indications for stenting with stent compression syndromes. Compression syndrome associated with the acute DVT, and then recanalization of chronic venous occlusions. The typical patient with compression syndrome is a lady in her 20s, 30s, coming with acute DVT, sometimes without any known risk for the DVT. And the patient is having progressive pain, and then they develop a high venous pressure later on due to the proximal occlusion. This is a venography image post thrombolysis, 40 hours. You can see nicely cleared up iliac outflow, but it's very difficult to recognize the compression point here. That's why the IVAS is absolutely mandatory to use. And this is, you can see the base of the atlas balloon, yeah, at the May-Turner point in the same patient. This was the problem of ATTRACT trial, so that's why it was so disappointing, because 80% of these lesions were left untreated, and that's why there was a high rate of rethrombosis, because these lesions need stent. Rethrombosis with anticoagulation is more frequent in the group where you leave these lesions untreated, and iliac patency after 1 year is significantly better in stenting. Yeah, this is what we know. You cannot just leave these patients with thrombolysis only. Sizing is extremely important, and if you don't use the IVUS, then you have a tendency to undersize the stent, and this can cause the rupture or even migration, which might be lethal. DVT is still very common, and is getting more and more frequent because of the population. The iliofemoral thrombosis is about like 1/4 of all DVTs, and it's likely to embolize. And almost all these patients with proximal occlusion sooner or later develop the post-thrombotic syndrome, which is a venous hypertension. That's why the proximal DVT supposed to be treated much more aggressively than by people because of the post-thrombotic syndrome. So the goals of the stenting is to relieve the pain. It works immediately. It's a very gratifying procedure, preventing venous hypertension later, restore the patency, and it's a first-line treatment for obstructive venous disease these days. It's recommended by all major societies, and we don't do open surgeries usually for these cases. The most common complication is in-stent thrombosis, which might happen early. Sometimes it happens during the procedure. That's why we use the heparin. Checking the ACT, I use not less than 10,000 units of heparin for all my venous cases. Late thrombosis around 5%. That's why these patients deserve follow-up. Many people are asking how about stenting in pregnancy. Stenting in pregnancy works. The venous stenting is not a contraindication to the pregnancy later on. There are like special consideration in it. Advise these ladies not to get pregnant within first 6 months, 1 year. You have to check the stent quite frequently, and then it's advisable to put the patient on low molecular weight heparins, especially in the last 2 trimesters. Contralateral thrombosis might be of concern, especially when you have to just push the stent all the way to the IVC, but it's not that common, and then you can just manage it with a thrombolysis and double stenting on the other side. If you don't extend the stent inside the IVC, it can result in ipsilateral thrombosis, and then you have to deal with it. So never compromise in this case. So what to be aware of? The most important, rather much more important than what kind of stent you're gonna use, is how you're gonna stent the patient, extent of the stent, and the sizing of the stent. That's why the IVUS is absolutely mandatory in these cases, and then you have to follow this patient up very closely. I usually spend like 1-2 hours talking to the patients before the treatment, usually with the family as well. Because they need to understand if anything happened, they have to come up back to very early, because even the instant thrombosis is very easily manageable if they come at the early stages of the thrombosis. Then you can just clean it up with thrombectomy devices or thrombolysis. Usually it needs extension of the stenting later. There are still some controversies. It's still not very clear, like if there are lesions, you might just leave without stenting, and we chart these lesions, how to identify them. There are no objective criteria for stenting for the venous hypertension, especially the pelvic one. It's not very clear how long and what kind of anticoagulation post-stenting is ideal. What about the follow-up scheme? How often to do the ultrasounds and when to intervene as well? And also, still controversial, to manage the DVT in pregnant ladies when you cannot just use the X-ray. So there are experimental cases using the IVUS or the ultrasound only. So the venous stents are absolutely necessary. It's a game changer. It changed completely the management of venous disorders. Uh, all stents basically work. Of course, there is need for the additional research in this field. There is a definitely need for a proper training, how to use these stents, how to do the sizing, and how to put the stent into the optimal position. And don't forget the IVUS is absolutely mandatory. So my answer to this question is definitely in favor of using the. I'm looking forward to hear from my brother, Dr. Omar, what he thinks about the topic. Thank you very much.